Okay, good morning all, and I'm happy to start this new live case web series, and which is now sponsored by the Heart.org and Medscape CME, and I'm with my colleague Dr. Keeney on my left side and my fellows on the right side with Usman Babar and Jeff Bender, along with my cath lab staff. Welcome all of you to this global audience to this live series of complex cases. As we have mentioned in our brief overview on the website, the focus of conference will be to teach and perform the technical steps of complex coronary intervention. Sometimes it may be a little superfluous for experienced interventionalists, but overall the purpose here is to put in together how can you do a complex case in a very safe manner. And with that note, I just ask my co-director of the live web series, Dr. Keeney, to make some comment, and then we'll start the live case number 1 of this new series which we have been doing for last 14 months so far. Anu?
Good morning, everybody, and welcome to this new series of live cases. Our goal would be moderate to complex cases. We will show step by step all the technical steps so that even a complex case can be performed safely in day-to-day practice of interventional cardiology.
Okay, now with that note, we will start with our we are not ready yet. The case, the slide of the case, because basically just to reiterate the format will be that we make a presentation of the case history, then the patient's angiogram, and then some relevant talks relating to that particular case for about 10 to 15 minutes, and the remainder of 40 minutes, major part of that 1 hour is devoted for performance of the case, and of course the live feedback, the question answers, with Mehta being in a moderation. Dr. Samir Mehta will be joining us very shortly, so that he'll moderate the live discussion. Therefore, I will encourage everyone, those who have tuned in, to type in for your questions, so that most of them will be answered online during this discussion or in the next 1 hour, and those will not, they will be answered later on and will be available on the website. And we will continue to need your feedback, how to improve this series further. Now with that note, this is the case number, we should have the slide 1, good. The patient is a 72-year-old male, has crescendo exertional angina and shortness of breath for 2 months, has a stress test which revealed multivessel ischemia, and is on antihypertensive medications and usual risk factors, does have the chronic renal insufficiency with creatinine around 1.8. He had a cath which revealed 3 vessel disease with the significant lesion of the right coronary artery, because of multivessel ischemia. Still the most significant lesion was in the inferior wall, has a normal LV function, and therefore at that time he has also disease in the LAD and circumflex, which we will show now, with a syntax score of 26. At that time he had a stents of the right coronary artery, and of course today is here for the calcific LAD and bifurcation circumflex lesion. Therefore, Anu will go through the angiogram. Always when patient comes back for stage intervention, the first thing is you need to check what the status of your prior intervention is, and this is where we will start now.
Just to go over the first step is even getting an access in this particular patient. This patient, knowing that he has been an ex-smoker and has peripheral vascular disease. His pulse on the right side was weak, so we did go on the left side. If you see here, the technique that we have started using in Mount Sinai currently is do an angiogram. Once you feel the pulse by using the micropuncture technique,
which is
two French, where you can go take a picture, and we knew that we were above the bifurcation, and after that we were able to just advance the 35 wire and used a long sheath to avoid the tortuosity of the iliac as well as the aorta.
And that's a very important point. Now the vascular access, as you know, in this day and age with the increasing sheath size, particularly for TAVI and so, the exact vascular access, how can we decrease the vascular complication is very important. The radial has been propagated, but still radial acceptance is very low. But second issue is the ultrasound guided, the recent trial published in JACC with the FASTO. But another which we are using at Sinai, using this micropuncture technique, and then if you see it's unfavorable, then you take it out, press it for 3-4 minutes, and then repuncture at the ideal location.
Okay. And this is the LV function. He had an EDP about 12. And if you see here the way we do left ventriculogram, that we have used JR catheter, very easy to get into the left ventricle. Do your left ventricular end diastolic pressure. That will give you an idea, especially if the patient has renal insufficiency, how much hydration you need to give the patient. Knowing that his EDP was normal to below normal, then we can go ahead and hydrate. And with the same JR catheter, we were able to inject about 6 cc's of dye, and with hard injection, we were able to have an overview of his left ventricular function, which is normal. And we looked at his previous right coronary with the multiple stents that he has had, and these stents are all patent. Good. And this is the picture with of the left system.
Anu, good morning. I've been besieged by so many questions as you have just taken a couple of shots, and I'll keep bringing those to you very quickly.
So if you see here, left main is non-obstructive, but majority of the disease is in the proximal LAD, an eccentric lesion. If you see the lesion with calcium in the proximal LAD, and the mid LAD is okay, and there's some moderate diffuse disease in the distal to apical LAD. There's again moderate disease in the proximal circumflex, his distal circumflex. If you see in this view, moderate size and moderate disease, but you have an OM, again an angulated takeoff with about 80% lesion in the ostium, and it's a large size vessel. And this is what we are facing with this patient, that we have an eccentric calcific proximal LAD and an eccentric lesion in the OM1.
All right, Samir, you can see here, maybe you can take over and start before I go on to our slide presentation. In this particular case, as I mentioned, I given the brief overview that our goal will be to present the case for 3-4 minutes, and then go with the slides for the 10 to 12 minutes, and then come back for the performance of the procedure. Now this case is peculiar. Now we have kept it, usually we keep very complex cases, but we felt that this is a real life issue, that once you have such a calcific lesion, how to tackle with it. You can see here, this, if you say the vessel size is 4 millimeter for the LAD, that only the top about 0.5 or maybe 1 millimeter or 1.2 millimeter is the lumen. The remainder 2.8, 2.9 millimeter is the chunk of calcium. And this is a real question, how to tackle with this calcific lesion. And knowing that now that many of our things have become quite simple, lot of emphasis on bifurcation and total occlusion, we wanted to put back emphasis again on the calcific lesion intervention.
Samin, in the meantime, I have been besieged with numerous congratulations to you, to Anu, to Mount Sinai Hospital for moving on with the heart.org. And one of the questions which came is, why have we partnered with the heart.org? I can reply to that because this truly will expand the global reach of your excellent work.
Excellent. Now with that note, let's quickly go while we are getting ready for as I mentioned that about 10 minutes, I'll try to do a little quick. The key is that all these slides will be available on the website, so that anybody can download later on. Issues with this particular case are threefold: choice of antithrombotic therapy, treatment of calcific lesions, and the bifurcation lesion intervention. And I'll focus more on the calcification in this particular case. Now antithrombotic, as we know that latest ACC NCDR data, that about 62% of interventions in United States are being done with the bivalirudin. And of course it is substantiated by our REPLACE-2, ACUITY, and of further Horizons trial showing the equivalent ischemic complication with the 2B3A and heparin, but significantly lower vascular and bleeding complication. And clearly everybody is aware of the Horizons MI with the benefit of bivalvulotin over heparin and 2B3A in STEMI patients, except that in the first few days there was a higher event, and that event was basically mediated by and occurred because of the early stent thrombosis. We know now that this early stent thrombosis happened because of the clopidogrel given loaded at the time of arrival. So that how can you eliminate, how can you get the ADP receptor blockers quickly? And we know the answers are twofold, most important being with the Procedural, which is available now and has a rapid onset of action, works within 30 to 40 minutes compared to 120 minutes with clopidogrel. Or secondly, which many people do, prolong the infusion of bivalvulotin to 1 to 3 hours and don't stop it at the end of the procedure. And there have been a lot of papers about it. At Sinai, we continue infusion on a clopidogrel naive patient for 1 hour, and we actually have eliminated this early stent thrombosis issue. And of course, now we have the data up to 2-year follow-up of the Horizons AMI, and I'm sure that the 3-year follow-up will be presented this week at the TCT, showing that benefit and the curves of the mortality continue to separate. Why? Because bleeding continues to remain low in the bivalvulotin group compared to 2B3A inhibitor, and therefore the bleeding has become a major important factor over even the myocardial infarction in this patient. And coming back to what we should be using, of course, routine treatment for our patients has been clopidogrel. We load them on the table. There are some issues, should you preload them night before? The many trials have shown now that loading on the table is good enough. The latest being the Armida 4, that loading on the table is equally good, and that is what we do at Sinai, 600 milligram load on the table on the naive. And those who are already on, that we just give a 300 milligram additional load. And of course, many of these patients you can test the platelet aggregation, but importantly now Procedural being available, that special patient setup of the STEMI, multivessel diabetic patients who are Plavix or non-responder or allergic and high-risk lesions, we are using Procedural, which makes about 30% of patients, and this is our protocol again, which will be available on the webcast. The second is the calcific lesions, that this is like patient which we have heavily calcific. Some little calcium, the flakes of calcium is not important, means you can go ahead with your regular business of pre-dilatation, don't do a direct stenting on those cases, but you have a heavy calcium like chunk of calcium in this case, and of course we'll show it by the IVUS. You have a big arc of calcium more than 270 degrees. Those do not yield well just to the balloon angioplasty, so that you need to do some additional stuff. And those are either non-compliant balloon, use a high pressure, or put a non-compliant balloon with another wire in the side. So basically you are doing a modified cutting balloon and do a high pressure so that you yield this calcific lesion. Of course, we have the cutting balloon. Problem with the cutting balloon, you cannot go to high pressure. Then we have angiosculpt, which you can go to high pressure, but many of these calcific lesions you cannot cross with the cutting balloon or angiosculpt, so that remains the rotational atherectomy, which basically works by the phenomena of differential cutting with the diamond microchips at the distal end, which ablate the calcific plaque into microparticles, and indication basically is the calcific lesion and undilatable chronic lesions. And many of these cases are the native vessel lesions where the bypass grafts are closed, but those lesions are very chronic, inelastic or undilatable, so that rotational atherectomy helps. Now this case by definition will become a calcific lesion because of the extensive calcium which you see irrespective of the cardiac cycle. Issue with the rotational atherectomy, as we very well know, this is a device which at one point has a very good wide acceptance, but then it fell down largely because of the limitations or complications. Two most common being the slow flow and no flow, and the perforation. Of course, the perforation can occur, and I can tell you over the years now, we actually have more perforation in the non-rota cases, because these cases like this particular case, you try to go to high pressure without doing a rotational atherectomy, your chances of perforations are much high. And of course, the various mechanism for the slow flow and no flow, largely because of this microemboli of the platelets and the debris causing the microparticle and clogging of the microvasculature. So that the goal there is that while you are generating the particles in a limited fashion, that you have a blood pressure high, systolic blood pressure over 100. Don't do a rotational atherectomy when systolic blood pressure is less than 100, and the short runs and wash out of the distal debris. And this basically are the settings where the slow flow occurs, which are the long lesions, total occlusions, and idea is the various technical modification which will help to decrease these complications. Now, we also have shown that the 2B3A inhibitors as well as the slow speed both help to decrease this phenomena of slow flow and no flow, largely because of creating small microparticles and less platelet activation. This was our original paper in Circulation with using epsiximab, which really blunts the platelet activation, and then subsequent data of the slow speed showing again emphasizing that causes a less distal microembolization and less slow flow. So, slow speed with the 2B3A in ideal cases has become a standard in these complex cases to avoid. The always question comes, how big should be your burr? We actually have done many trials, the major being the Stratus, where want to go to a high burr to artery ratio of 0.8, 0.9, basically found that it created more problems, more restenosis, more complication, so that the verdict basically is now your rota burr should be about 0.3 to 0.5. That don't have to be hero in terms of the big burr size, but just about 0.3 to 0.5, because lesion modification, because subsequent outcome of the patient will be dependent on the stenting. And perforation of course occurs in the angulated lesions, so need to be careful and use a small burr with the careful technique. And these are the data at Mount Sinai, that overall complication rates have decreased over time by the techniques, and slow speed really works very well. What we also have done for the audience that various steps of rotational atherectomy in terms of physical principle, indications, and steps for the operator, and the techniques of rotational atherectomy in these 4 slides, which you can go over later on. The purpose there being is that go through step by step, so that these again the whole symposium live series will be focusing on the steps of the technique. So many of steps we will just put it on the website, so that you can audience can come back and later download as well as go through them. Issue comes that does Rota works with the DES? We know the BMS, overall there was never a benefit, but clearly that it has shown that the DES, this is the one we presented last about 2 years ago, that overall restenosis decreased to 5% from 15% versus BMS. Now, the issue remains still that why to do rotational atherectomy, because if you can have a good stent expansion, that's where the key is, that if you have good stent expansion, that is what determine your DES outcomes. Second, what should be the DES length post-rota, because many times you do ablation in a long segment. Should it be the ablated area or lesion coverage only? Very simple, the area which you post-dilate with a balloon, that should be covered by the stent. And lastly, there is no randomized trial. There is a trial called Rotaxus, a trial which has actually started in 2006. Only there is no further noise about the trial, but maybe a trial will ever be done to answer this question in a more prospective fashion. And lastly, the bifurcation issue, which we actually have focused as well as emphasized numerous times, that various bifurcation with the Medina classification, like this particular case, actually will fit in. If you go to the LAO-caudal view, which I didn't give too much dye, we have the diagnostic picture, it's the Medina 111, because those are the most common and have a higher complication rate in terms of side branch closure because of plaque shift and so. And there is a second classification called MEDS, based on where you are going to put your first stent, and I have just incorporated for the discussion, and the various technical issues, important being which we will discuss in this particular case, that what should be the right strategy from the wiring and 1 stent versus 2 stent strategy. And clearly that 1 stent strategy is the preferable, because if you want to put a second stent, the issue is that you leave a gap, have a high restenosis. Therefore, many techniques have been evolved or has been advocated in last few years, which have a 2 stent strategy and have a good coverage of the side branch. And of course, ours being the kissing stent, where you put 2 stents side by side and inflate and create a small carina. Now, the people are very much concerned about that should you have a 2 stent versus 1 stent, but I can tell you that we had done this, this is our publication in the Nature as well as in the cardiology clinic, that the 2 stent strategy done correctly, as you can see in the recent time, is not associated with any high high restenosis. The MACE and TLR shown here, 1 stent versus 2 stent, or the stent thrombosis you can see. So that basically my statement is that 2 stent strategy, yes, it has not shown to be beneficial, but if done correctly, may be beneficial in special settings, particularly when there is an angulated lesion or there is a long lesion of the side branch. And of course, the dedicated bifurcation stent is still far away before they can come for the regular clinical use. Now, with that note, I will just go back to our performing the angiogram, and Anu has already engaged it, and we are ready to do an IVUS of this calcific while you take some questions and we answer the questions.
So, I mean, first question which has sprung out is, why has it been so hard for the company to improve the Rotawire?
Yeah, that's that's a very big, I think clearly that it's a part of the hard technology, then of course taken up by Boston Scientific.
Wire with the Rotawire?
Yeah, yeah. That,
Or wire first?
Yeah, first the IVUS, right? Or you want to do the IVUS on the Rota? Yeah.
We can do that.
Yeah, yeah, yeah. Clearly that I would say that the Achilles heel of the rotational atherectomy is your Rotawire. That if there can be some improvement done, and particularly you make it a 0.014 wire, I can tell you Rota use, which in the country is about 2%, at Sinai is about 6 to 7%, which will double overnight because of this Rotawire issues. Now, Anu will show actually this the technique in terms of the taking the Rotawire out and making the curve on this wire. If we can focus there, yeah. Good.
So, if you see here the Rotawire, which is a 300 centimeters, a stainless steel wire, which comes this way once you take it out from the packet. Very important, this is the Rota clip, which you can take it and keep it aside. And if you see here, this is the distal end and this is the proximal end, which comes with the blue covering. Now, you cannot take it out unless you have disconnected the distal end. That's what you need to take it out first, and after that you can just slowly tug and pull this out. You have to be very careful, because this is the time when you can cause any kind of a bend in this wire. You cannot have any bend, and that's when your rotabur will not be advancing. Just take it out and nice smooth movement to clean it, and you can make 3 loops to keep it, and at that end you just make a curve at the tip, and this is ready for us to wire it now.
So, I mean, a question.
But you are right. I mean, I think the Boston Scientific folks should put little money. I know that all has been in the DES technology, that if you can just change the wire and of course the burr to accommodate the 0.04 will make our life so easy.
Well, with the expanded viewers we are having today, I am sure a lot of folks are listening, and hopefully some engineers will get behind this task.
Yep. And make it a monorail. Other point we actually have seen that once you make it a monorail, clearly the use of ease of device use becomes. So now we actually have done, the Rotawire has been advanced, and now we'll do a IVUS on the Rotawire.
Yeah.
Now many people actually do the stent and so, but we don't do the stent on the Rotawire, because after the Rota we put a regular wire. But in this particular case, we already have the Rota easy. Now in difficult case, don't use the Rotawire directly. You need to go through the your regular wire, workhorse wire, and then exchange. But in this case, we are ready for the IVUS.
We have the Galaxy IVUS system.
Our iLab.
Okay. Forward.
Go.
Just to let all our viewers know that let your questions keep coming at info@ccclivecases.org, and we'll try our best to answer most of them. The others will be posted online.
Let's start the IVUS.
So, I mean, how much is the use of IVUS at Mount Sinai?
Well, I mean, actually now it's increasing, and particularly the more so in terms of the lesion determination, rather than the stent expansion rarely, but mostly with the lesion determination, and it's gone to upwards of a higher teens number. Now you can see here we are getting to the calcific area.
Yeah, this is where that exactly where the lesion is. Actually, at one point it's almost close to higher than 180-degree calcium.
No, actually the one, if you will play it, that it's probably not complete 360, which you could have predicted based on the angiogram also, but clearly that almost like the 270 plus.
But interesting is not, it's superficial calcium, not that much of a deep calcium.
Okay, flush it and keep it there. So now then question comes that usually we are one burr case, majority of them, there should be a single burr, and in this particular case with a large lumen with a 4 millimeter vessel, that the burr choices are 2.15 and 2.25, and this case actually we decided to start with the 2.15 because maximum burr now available is only 2.25 now.
So usually the console is kept ready, and as you see here in the console you have one which is connected to the nitrogen tank, and this one that is a fiber optic which is going to give us our RPM, and here is our flush. And what happens is if they have it ready, the flush is usually disconnected. So what you have to do is make sure you are open and you see the flush that's dripping. That's the only way you know now we are ready to go in with the rota.
So I mean, even with your expertise, how much of an angle will you never do with the rotablator?
Well, actually sometimes what we have seen, some of the calcific angulated lesions, that there is no other choice, that you need to do rota and then just try to use a 1.25 bar. If we can avoid rotational atherectomy on those angulated lesions, let's say the 180 degrees and so, tortuosity proximally, but otherwise angle itself, and if it is calcific, the only way you can do is by doing a rotational atherectomy.
So those would be the cases you would further undersize below the 0.
Absolutely. Good.
Where's the
So I mean, another question, have you started using the OCT and how is that going to complement IVUS?
Well, actually very good point. The believers of OCT says that IVUS is history, but we actually will do the OCT in the end after the stent deployment, because I think the OCT is not going to help much here. IVUS could help because of the calcification which we saw, but OCT we are definitely going to perform in this particular case at end of the procedure. Go.
Okay, once the burr is close to the Y connector and the wire has come out of the advancer knob, very important, you put this safety clip at the end, and then you check your speed. Increase the nitrogen.
No, press proximally, no, not inside, outside. Yeah.
Okay, now we have about 160 speed. Good.
About 155 outside, which will translate into 140 or so inside in the body. Don't wait too much time, spend too much time in terms of speed, but as long as you got to about 150, 160 is good enough. And then push and pull like any other device being advanced into the vessel. Now this is the 2.15 2 bar actually, and even 2.15 can have a tight fit with a 7 French guide. 6 French guide will take a 1.75 bar, but if you need to go to a bigger bar, in this particular case we thought we might need 2.25, we have gone with the 8 French guide. Look, now bar should be pulled enough room so that you should be a little far away from the lesion as much as possible. Yeah.
And the 3 important steps that once the burr is in the proximal part of the lesion, what you need to do is, first thing, you have your advancer knob, this one, so which is right here. You can just lose it and just move it backward forward. By doing that, you are going to remove the tension between the Teflon sheath and the burr. Next you go on fluoro and you release your Y connector and manually move the burr backward forward a little bit. So any tension between the burr and the wire is removed. And the last one is when you are on dyna, just may do a tap. You see that the burr never moved. If there was any tension still present, that the burr would have moved, but with a very small RPM. Now we are ready to do the rota. We have given angiomax, the ACT is 360. And same thing, slow pecking motion. Every time I am going forward, but very little. At the time the nurse is giving us the RPM, and you keep flushing forward. When they tell you 20 seconds, you pull back, come to the normal portion of the vessel, and you stop. So far the blood pressure is good, the heart rate is good, so we'll do our second run now.
Because I was thinking whether should we use a 2.15 bar as a single, but I think that would have been a little issue here.
No, this is 2.15.
Yeah. No, I'm saying 2.25 bar.
Yeah.
Sorry.
See, I was actually surprised. I thought your choice would have been a 175 here because of that, both the slight angulation and the eccentricity. But you're also right, it's a very large size vessel.
Yeah.
But you see at the distal portion, we are having some trouble, but that's okay. We can still be able to.
That which is expected now. The question here was the 2.15 bar decision just was because of single bar. If you use a 1.75 and 2.0, which was correct, then you definitely guaranteed you needed to use 2 bar because of such a high chunk of calcium. So that's why the 2.15 we thought that let's compromise, and we tried. Now clearly in these cases that if you think that it's taking too much time after 4 or 5 ablation or maybe 6 7 ablation, then you can always downgrade the bar.
And this is the most important part of the rotational atherectomy actually when you are at the distal end of the lesion, that you have to be really careful. That's your exit, that if you are trying to push thinking that that's it, a couple of millimeters left, let me just get the burr through, that's when it can perforate or also cause a spiral dissection.
Now other thing we can do, if you see that you do few times and it doesn't go, you can increase the speed up to 160, because clearly according to David Oth, ablation efficiency does go down at a speed of 140. So that after 4 or 5 runs before downgrading the bar, we'll try to go to 160,000 RPM. That was actually original recommendation, as you know, with the FDA when the device was introduced, but we all actually have gone to a smaller burst now. Lower speeds.
And this patient is tolerating the procedure very well. His heart rate, blood pressure, everything is stable. While we are doing this kind of ablation at any stage, if we see patient has hemodynamic compromise, that's an indication that you may have to downsize the burr.
Hold back and wait. Yeah. This is, well, 2.0. Always the issue comes. Now sometimes also, when you see that things not making sense, pull back the bar, but has to a little room and then take a picture. Will tell you where you are. Now I think things are okay here, that we need to go to a last few millimeter. Rest is actually has done a reasonably good job.
So what do you propose?
No, I think we still do a 2 more.
Okay.
2 more run, and if necessary, one of them we can go with a 160 RPM, 160,000 RPM.
A very panicky and disappointed viewer has asked that he is just tuning in and what should he do? No problem at all. The entire web will be archived.
Yeah.
So not only this case, but the previous 14 cases, they are all going to be online, and whenever you have time, you can review them at your leisure. In the meantime, we have a lot of technology in the back of the room. We are watching our presentation on the
175.
on the iPhone as well as on the iPad.
You have the 2.0? Okay.
Just try one more. Good. Go to 160,000 RPM.
Yeah, we are 160 now.
160, good. Go one more. Yeah. Okay. Pull back. Fine. Yeah. So now clearly we have done total ablation of about 3 minutes, and burr did not go. Just 1 second. Make sure when you are ready to pull that your wire is straight, is not bent, because it's very likely to bend now. And we'll go with the 2.0 bar. Now you could continue push little hard, but no. The purpose there is absolutely no. That you try to do as much as possible, easy. If you can go through, fine. Otherwise, you just go to the different bar. the downgrade bar. We are done. What is required? One is the increase the speed and consistently about 5, 6, actually more than 5, 6.
So, I mean, one could argue that if you have to downsize, then the incremental gain will come by decreasing straight from 215 to a 175, then a 2.0.
Actually, you know what, I'll tell you one, what happened is that in a preparation, they actually had ready with the 2.0 bar.
Okay.
And maybe since otherwise, yes, using a 1.75 and then go to the second bar would have been approach also. But so far patient tolerating very well. Anytime you start getting a bradycardia, make sure you use atropine or in rare cases a pacemaker. But the patient so far has been tolerating all our ablations quite well. And actually I think we should take a picture now, although with the creatinine we can do a little flow.
No, we can.
Diluted.
Creatinine is normal. Yeah.
Good. See the last few 1 millimeter, see, but that's okay. Means we gave it in a gentle, just that's the point we want to make, that although we have a clear-cut planned strategy in these complex cases, but as case goes along and the directions can change, particularly depending on what you encountered in that particular case. Like in this case, we were ready with go with the steps quickly again with the 2.0 bar. Good. Yeah.
Anu, despite your experience of decades of using the rotablator, you still always use the same 3 steps?
Same 3 steps.
Every case?
Yeah. I tell the fellow that even in the middle of the night in their sleep, that these 3 steps should not be forgotten.
And this is again the all part of the teaching. So that what I did is that for all the fellows, my intervention, we have 8 of them, that we told them that send me, write down the steps. So once they write, they know that now they are not going to forget.
Again 3 steps, backward, forward, and then movement with the dyna. Good.
Okay, there you made the pass.
But same, it has to be a smooth, nice pass, no jump with the bar.
So, I mean, excellent demonstration of techniques. Truly the purpose of doing a case like this, you start with the device, you think it is going to work, you take a step backward and do it safely.
Get the wire.
Yeah.
So,
No.
we have the run through? Yeah. Good.
Yeah, therefore now what we'll do, that question will come, that should you go with a 2.15 bar at this time? I'll tell you the modified way. What we'll do, leave the rota wire, put your side-by-side wire and bring your high pressure balloon. If you can crack the lesion at 810 atmosphere, fine. Otherwise, you just go back to your higher size bar. Like in this particular case, we already have the 2.15 bar available. But in this particular case, now meanwhile, you can throw this bar, attach the second bar, and they will dilate side by side with the balloon with the wire there. And if lesion does not expand, so don't go to very high pressure. And if required, just go with the bigger bar. But if not, if cracks up, then no. This is okay. Now we have a 3.5 20 NC Voyager, and this is what we are going to do now.
So at 8 atmospheres, you are looking at a full expansion of the balloon?
That's right. If not, then we have a 2 point, our bigger bar, and we are going to take care of that.
In many ways, you are extrapolating how the stent will expand.
Yeah. I mean, that's the whole goal was here, that because of such a high calcium, that are we going to expand the stent? That basically, and that is where with the DES, actually the further decrease in rota occurred, because everybody knew your ultimate goal is the stent expansion, because that is what determines patient's restenosis, and so that it will be reasonable that in those cases that if you don't expand, then only you use a rotablation, and if you can crack the lesion even with the high pressure, it's perfectly fine. Now we'll pull back few millimeter. Good.
We'll see if it expands. We'll need a 4O. 4O23 ready?
No, this is good. Now this is actually, you can see here 8 atmosphere. Again, you know, few things you have to do by the protocol and principle. And this is 8 atmosphere, and this is where our lab actually all has been about, that working with the protocols. 423.
Samin, have you used the strategy sometimes initially also without going with the rotablator, just putting in a balloon, seeing at 8 atmospheres it doesn't do it? That is when you will use the rotablator?
I would say a lot of people will do it, but not in our cath lab, because from our point of view, this kind of case, you need to just go with the rota. But yes, that's another way, which I mentioned, that a treatment of a calcific lesion is nothing wrong in that. But at the same time, don't go to 20 atmosphere and cause the dissection and saying that now you cannot do the rota. So in this particular case, although we have attached the burr, we don't need it. Remove the burr, please, because many of these, once you are done, remove it from the table so that area will be clear.
Take a picture.
Yeah.
Yeah.
Good.
And also, Samir,
28? No.
28?
28, yeah.
That will cover the
23 is good.
You see how we did it. We dilate, we take the balloon, we leave it in the guide, and we take a quick cine. In the rare cases of a perforation, you have your balloon there, so immediately you can go in and use the balloon to tamponade out the vessel immediately.
Good.
Samin, one of the persons has asked, when would the archive be available for viewing? You will have it online by Thursday.
Yes.
And we are trying to even expedite it in the future cases, hopefully even sooner, but Thursday it should be there.
Yeah. And also, now with this, our lively and active website, that all the questions, if need to be, and more importantly, that we guarantee you that we'll answer those questions as the time will permit in the very short time period. But any particular advice, type of case need to be done, take the rotawire out.
Yeah. I'm sorry. So now that we have positioned the stent, now the rotawire, which is, will take that rotawire out. Leave it there.
Samin, there is a question by a Dr. Ghazi Malik. I don't know the origin of it. I'm going to read it exactly because I want to capture what he's asking exactly. What torque setting of the rotablator are you setting?
Okay.
I'm sorry, say it again.
What torque setting of the rotablator are you setting?
RPM, you mean?
I don't know. That's
Yeah,
why
that,
I think
that
he would
basically
have
means RPM. Yeah.
So that was
150,000 RPM outside the body, and in the vessel about 140. Now this is a 4023 Zions at 12 atmosphere. Don't go high because will cause edge dissections, and then you post dilate with a 40 balloon at high pressure. So we can take a 4020 NC Voyager, and then we post dilate.
I think the question may have even, I think he would have probably asked when you had increased the burst speed to 160.
Exactly. Yeah, that basically was issue that we did at a 140. It was not going through. We went to 160. Now clearly with the larger burr, do not go beyond 160, because remember original even recommendation was 160 to 180. But when you're doing ablation should be about 160, so that in the larger, smaller burr you can go between 180 to 200, which is 200,000, particularly in the burr less than 2 millimeter. Once you are 2.15, do not go to higher than that.
I mean, many
so we
questions.
did go to 160.
Many questions I'll quickly take. They are coming through regarding the stents. What is your preferred stent in your cardiac catheterization laboratory, and why?
EKG.
Yeah, no, clearly that in this particular case and otherwise also, because by virtue of all the trials coming very positive for the Zions or Promus, basically everlumus eluting stent has been the preferred, and that actually supported by personal data as well as the data by the various randomized trials.
What is your preferred stent for a bifurcation?
Yeah, bifurcation still many of those cases we are using cipher and so, but majority of them still we are going with the same with the Zions, and has been excellent results. but very important question which I know many people are asking me, that the issue about the thin struts and able to expand in a calcific lesions. Now this is the project which we are starting now and going to will be submitting for ACC, which is on October, the mid-October is the deadline, that we are going to compare our experience of the Rota with Cypher or Texas versus Rota plus Zions. That basically to show that is there any difference in restenosis, lumen, side branch, acute as well as long-term results up to follow-up of 1 or 2 years. So
optimal pressure for a Zions V expansion.
12, then post-dilate. This is a 4.0, 20 Zions, the NC Voyager. Within that Zions, knowing it's a 23 millimeter, I'm within it and went up to a 20 atmosphere. 20 maybe we can go to 22. Sometimes in a focal area you can go a little higher.
And another very intriguing question regarding what is the percentage distribution of the DES in your cath lab?
Yeah, the percentage means the overall.
Yes.
The DES is used in about the latest one is about 83% cases, and of that 83, if you consider 100%, the 85 to 88% will be between the majority Zions, some Promus, and then the Endeavor used in about 5% of cases. Texas is almost minimal, and Cypher in about another 4-5% of cases, and those cases are the bifurcation, some ostial left main and so. But Texas, only I would say the indication for Texas now is recurrent sirolimus DES restenosis, and because the data have shown that it's not that it was better in the diabetic, but everlumus did not have advantage over the paclitaxel Texas stent in the diabetic, but not that it was inferior. Though I think that based on those data, we are fully comfortable that even in the diabetic patients, that everlumus, because of the ease of insertion and so, is the best stent to use for various reasons I mentioned. This patient developed a lot of EKG changes, but not surprising, and this is part of we are going to get little verapamil, because microembolization probably with that extensive burring, not expected, not unexpected. There was a very small diagonal which we'll try to see, and clearly the advantage of the second generation stent, one of the big has been that they do cause less side branch closure of these small vessels, particularly even overlapping. The data basically with the Texas, that overlapping stent was associated with very high stent thrombosis, restenosis and so, and clearly we have seen with the second generation stent, both true for Zions as well as for Endeavor, that associated with a lower side branch closure, lower myocardial fraction, personally as well as all the randomized trial actually have shown that.
Anu, a few questions for you regarding bivalirudin. Are you always using bolus and a drip? Are you following the ACT, and when do you stop bivalirudin?
Yeah, so interesting is same, what percent of cases we use bivalirudin versus heparin. Actually in the last 2 years, majority of our cases, over 95% of the cases, we are using bivalirudin, bolus as well as drip. And what we do is bolus, we give it through the arterial sheath. Once we know that we have decided any cath possible cases, or even if you are saying that patients have come for a stage procedure, definite ICS case, once we know our sheath has been inserted and the access site is good, we give an bolus, and the drip is started at the same time. At 5 minutes interval, we do check an ACT. I know the recommendation is that you don't have to check ACT and do the procedure, but we always do check an ACT. ACT is very important. If it's a straightforward case, just say a direct stent of mid RCA, mid LED is okay, but when you are dealing with the bifurcation intervention, or you have difficulty in delivering the stent to a distal portion of the vessel where you're going to use a double wire, multiple wires, 2 balloon technique, you need to have your ACT above 300. Otherwise, we have seen cases of slow flow and thrombus formation in the vessel in the guide.
Excellent. In the meantime, if you would have noticed, we've done a quick 30-second review of the entire case, showing the diagnostic pictures to where you are in the case. Samin,
that all the branches are basically,
he
does have a very little ST depression in the inferior lead, and I saw that all the diagonals were patent. There was a very small first diagonal which was severe diffusely diseased. Now see that here the stent has nicely expanded, but we are going to see that whether stent is opposing the vessel wall, and now the question came up that can we do the OCT, or is OCT better than IVUS? I can tell you I have no authority on it, but I can just show both the technique. We have done the IVUS at the baseline, and now we are going to show the OCT in this case post. And if you ask me that where the OCT will pan out compared to the IVUS, one of the big issue has been now the cost point of view, and where we are going to use it. One of the important indication will be that whether stent has been endothelized. I think that's a very important case. High risk patient is going for surgery, that the endothelization of the stent struts at follow up may be the useful.
What
Now
about what about the evaluation of thrombus?
And I would say absolutely yes.
Anu, you were
I was earlier question, when do we stop the angiomax?
Yes.
So the drip in two situations, if the patient got the antiplatelet therapy, Efient or Plavix on the table, then we would continue the angiomax for an hour post, just to make sure your antiplatelet therapy will be working. Otherwise, if the patient has been already on Plavix, then we will stop it at the end of the procedure.
So, a very fascinating question. With the latest syntax results in intermediate risk patients, how do you think this will affect the interventional practice?
Yeah, intermediate, actually the data which came out in the JAC only speak for the diabetic patient, then again was with the based on the TLR, and I'll come back to that question. Basically in diabetic, even in the intermediate, you might have a little benefit with the bypass surgery, but not in the non-diabetic. Now just go over 1 second. Now they want to show basically.
No, let's make sure it's working.
Okay, good. So now we are actually doing the, are we ready with? Okay, now you can see the camera on the other side.
No, it's shown already.
Good, very good.
Yeah?
Good. Now this actually requires that you have to inject the saline to clear the field or dye, and basically the newer generation of the OCT will require that maybe you can do it with the blood field. Now it's a rapid, a few seconds acquisition.
Yeah.
How many seconds? And you see the pullback. We are coming back from the distal vessel to the proximal, and we'll come back to that the level of the stent struts. Very, very rapid acquisition. Yeah, you see that stent struts now.
Yeah.
Nicely.
Now you start seeing it. Yeah.
Good.
You want to do one more run?
Yes, I think that would be very instructional. Samin, are you happy with the stent expansion there, and how do you, I think it would be very usue to see IVUS also after this.
Yes.
Okay, we can do that. We'll do one more.
One more run of this and IVUS, and I think we'll do basically the circumflex intervention we'll do offline.
Okay, how are we? Yeah? Ready? You need some workup before you start doing OCT.
And actually the assist device may come handy here, that you can inject large amount of the saline at a speed in these cases, and we actually have in a process of acquiring it in our few rooms and try to see, and that actually will be useful for the TAVI procedures also, because many small aortograms will be required, and that really very handy compared to the MADRAD, where you go through the multiple rigmarole.
So, another.
Okay, now you start seeing the. I think it's a good, yeah.
Yeah.
Well,
and we can stop at that area where we see the stents. Go back. So that just can we take this one out on floor so that we do the IVUS. Show at that area of the stents. Yeah. Now key is that most important with the OCT. Yeah, good. See, those are the stent struts nicely opposed. That a lot of post processing can be done. Good. Take it out.
I want to do one more at the level of the stent.
We did already.
Yeah, good.
Done.
Okay, get the IVUS ready.
Yep. Yes.
So, a question has come. Is your PCI volume affected due to FFR?
Actually, we are not big in the FFR yet, but the many of these cases, more and more we are learning that as shown by this Jack interventional recent paper, that once you decide that FFR definitely will decrease your stent use, only
Did you
30
flush it?
will go down to 33%, compared to if you are doing based on IVUS is about 90+%. So that it will go down, but clearly to me I still say the utility of FFR is to decide in the multi-lesion, multi-vessel disease which lesion should get a stent, and you can get away from putting multiple stents and without paying any penalty in terms of TVR, MI and so. So that to me is the most important, will be the utility, go a little further, utility of the FFR, and that is what we use in many of these borderline cases. We show the IVUS now?
Yeah, go.
We can make the camera on the IVUS side, change the screen. Yep.
Yeah, see these pictures we are calibrated to. The OCT is still going to require a little time to, but just by looking at this, one can appreciate how dazzling the OCT pictures are, and you can virtually see every stent strut.
So now if you see here, you have a good stent opposition.
Yeah, although that area, one area in the center, you see still there is a less, we'll check into the lumen cross-sectional area, maybe will require with the 4.0 just 8 millimeter and go to 4.5, just in the short area to about 20 atmosphere in the middle part of the area lesion which we saw it in another view. Yeah, take this out.
Samin, you had mentioned that your Procedural use is about 30%. What are the cases where you are using Procedural?
I would say the most important group which actually we are using now, because we do lot of Plavix testing in the Plavix for the platelet inhibition, and that's a very important and big group. Now anytime when you have a particularly less than 20%, which we call non-responder or hypo-responder between 20 and 40, those patients in my opinion are clearly, then we switch it to Procedural, and as well as those don't have contraindication in terms of bleeding or did not have any CV and so. More importantly, what we have done is that majority of these patients we are going with the 5 milligram. I know recommendation is only in some subgroups go with the 5 milligram, but in majority of these cases we are putting a 5 milligram because it's a very potent drug. And the recent meta-analysis which was in the heart.org yesterday, a lot of in the interventional cardiology, that paper comparing ticagrelor with Procedural, clearly that the Procedural does cause high bleeding, particularly when you are talking about giving 10 milligram routinely. So that our policy, and we actually have done many patients now on the 5 milligram the platelet inhibition, and I can tell you majority of them, majority B, I'm talking about 98+% have over 40% platelet inhibition as measured by Acumetrics. So that 5 milligram, unless somebody is very obese or has a multiple stents, our routine strategy has been give the bolus 60 milligram and start with a 5 milligram daily maintenance. If they are already on Procedural and come, that don't give even a bolus of 30 milligram or any, just give them their morning dose of that day 5 or 10, and you proceed with the without giving additional bolus. Region is very potent drug, very effective, and therefore you need one only concern on the drug is the bleeding. With that note, I think we are reaching to the time, and if it's okay, we can just this is the last picture. You can see a nicely expanded. We have a very small area of the which we can do offline, just little dilatation of the mid LED stent, and we need to put a stent in the circumflex. In this bifurcation case, my strategy would be knowing that there is a disease only in the distal segment and so not a large vessel. This is the ideal case of a stent crossover, single stent from the proximal circ going into that large OM. With that note, I would say
what stent size and type would you use there?
In this particular case, I would use it's a large vessel. I will do a pre-dilatation using a 3.0 15 NC Voyager and so, and then and then deploy a 3.0 28 millimeter stent, and then post dilate probably with the 3.25 or 3.5.
Anu, excellent case demonstration, stepwise use of the Rotablator, wonderful techniques, increasing your margin of safety. What would be your summarizing points today?
Yes.
Take home message, Samin.
Therefore, if we can just get back to our last slide, that rotational atherectomy is a useful adjunct device in interventional treatment of heavily calcified lesions, like this kind of case. Even you saw it, even with that by the burr with the 2.20 and then 2.15, one area was remain very recalcitrant, that which we clearly at 12 o'clock, that not full expansion. Of course, we go with the 4.5. Otherwise, you go to high pressure, you have more chance of perforation. In my opinion, in a heavily calcific lesion, rotational atherectomy actually will decrease your complication and particularly perforation. Second, of course, the optimal technique and strategy are crucial to avoid any potential complications, and the issue always remains is that are we doing good in terms of using a rotational atherectomy in the long segment and then doing just implanting the DES in the area which you post dilate. Means after rota, whatever your length you dilated with a balloon, that should be covered by the DES, not entire area of the rotational atherectomy. With that note, I think we can just come back to the last statement from our cath lab, that this complex case, I hope we were able to emphasize many points in terms of performance of rotational atherectomy and changing strategy as go along, and able to show this new technique of OCT, although we all are learning, and maybe next time we'll get some expert to make a special comment on this technique, which I know a lot of people are very excited about, but I'm very cautious about this imaging technology, but we'll continue to incorporate in our interventional cardiology.
Samin, congratulations to your team. Excellent demonstration of the case. This also concludes our session number 15 for the CCC livecases.org, now with the new partnership, this time with the heart.org. All the cases will be archived. They will be available by Thursday with answers to all the questions which were asked. Session 16 will be October 19th, 2010. Join us at 8 o'clock. We'll follow exactly the same format, have a genuinely complex, challenging case, and have an excellent review of the pertinent clinical trials, take-home messages, tips and tricks. Happy to have you join us, and we'll see you next time.
And Anu will make a last statement.
Anu,
just want to make sure for the viewers that whatever kind of cases they want to learn, what kind of cases they want us to show them, that would be very good, so that they can put it on the website, so we can be ready with this kind of cases. They get us more questions regarding that. If you see here, I think the most important point that we taught in this particular case is how to do rotational atherectomy safely, and the tip for the operator would be do the rotational atherectomy in some simple cases with moderate lesions, so they get comfortable. After doing 2 to 3 cases, then they go to the next level of moderate, the heavily calcified lesion, so that they know how to tackle this device if at all they end up with any complication. And I would like to thank all the cath lab staff. This program busy, and we would not been able to do this amount of cases with very low complication without the help of our interventional fellows. You see, we have between 8 to 9 interventional fellows every year. Today we have Usman Babar and Jeff Bander, who has helped us with this case, and they already in their 3rd month, and they are doing this kind of moderately complex cases with us, almost as a primary operator. At the end of the fellowship, they are ready to do these cases completely independently. And thank you, everybody.
Okay. Take this one out and put
we
it
will
there.
see you next time.